Julie, how's the chief doing? Is she going to be joining us?
As far as I know, I haven't gotten any notice that she's not. So, in fact, I haven't heard from her since the executive committee met. So you know as much as I do about how she's doing. Hopefully well. And Dr. Box is also supposed to be joining us this morning, but she had to meet with Commissioner Lyles right at 10, and then so she's going to join us right after that.
Okay.
Okay, we do now have a quorum.
All right. I want to welcome everybody, and I want to thank Julie for continuing to do a great job on putting this meeting and virtual meeting together. It's, I don't know, hopefully it's not a new normal, but it really seems like it. And I believe our next meeting will be done the same way as we get close to session. And I think most of the buildings are starting to get used up. Do we want, I guess we can just continue on with the agenda items. And I was a little bit reprimanded that we're going to start using, or not start using, but we need to use our Robert Rules of Order. So on a consent agenda, I need to get a motion to approve the consent agenda, which are basically the minutes from the last meeting.
Sorry.
And a second.
Second.
All right, all in favor? Say aye.
Aye. Aye.
Aye. Opposed?
Aye.
Vanessa, was that an opposed?
No, I was eyeing the eyes. I was late.
That's the earliest you've ever been late though, Vanessa. That was really good. So welcome. Thank you all again for coming. And I know we're going to jump right into the meeting, and we'll start with agenda item number 3, which is child trauma and resilience, is David Westberger and Dr. Zachary Adams. And if everybody else could mute their screens, that would be great.
Well, good morning, and thank you for having us this morning. My name is Zach Adams. I'm a clinical psychologist on the faculty at the IU School of Medicine and the Department of Psychiatry. And along with Amber Becker, I'm one of the co-chairs for the Child Trauma and Resilience Committee for the Children's Commission. And we're delighted to be with you this morning for a couple of reasons. So the first reason is to just give a very quick overview or description of our committee and what our role might be. And the second is to share with you and ask for your endorsement of a position statement that I believe has been circulated in regard to the appropriate use of ACE science, ACE scores, adverse childhood experiences. In just a moment, my colleague David Westenberger, who's an ACE interface trainer and the CEO of the Indiana Youth Services Association, will share an abbreviated version of some of the material that is shared with youth serving professionals across the state of Indiana and really nationally as part of work that's been led by Dr. Robert Anda, one of the principal investigators of the original ACE study. And the reason why our group has discussed the need for a statement like this really dovetails with a couple of national movements. So the first is the growing awareness and attention being paid to the potential harms associated with adverse childhood experiences, including maltreatment, dangerous and harmful environmental contexts at home and in the community, and the long-term consequences on health and well-being that those can have for children and certainly on into adulthoods and even across generations. While that enthusiasm has been has brought a lot of good in terms of attention and resources to this topic, there's also been some concern that the application of those ACE scores has outpaced the evidence in a specific area. And that specific area would be moving beyond surveillance, population level surveillance, which we would support and continues to be an appropriate use of ACE scores into individual level screening, or in other words, to make decisions about individual level care. So those are the points that are outlined in the position statement. Hopefully, if you haven't had a chance to read it, you can take a look today. I did want to, David, if you could advance the slide. I did just want to note quickly the composition of our committee. So this is the statement that you've received has been generated with input and approval from this committee. And you'll see that there are folks who represent various sectors, both within state government and outside, from all sorts of youth serving agencies and systems. So with gratitude to that group, but also to introduce them to this body today. So with that, I'll turn it over to David to share a little bit about the context here, and then we'll come back at the end to discussion that folks might have.
Great, thanks, Zach. Can everybody see the screen okay and hear me okay? Okay, great. Again, my name is David Westenberger. I'm the CEO of Indiana Youth Services Association. I've been fortunate enough to work with Dr. Anda for about the last year and a half to bring not only Dr. Anda to Indiana for some presentations, but also for training of 2 cohorts of master trainers on ACEs, which means we have 50 ACEs master trainers in Indiana. Our normal presentation on ACEs, and usually we allot about 2 hours, but Julie said I could not have 2 hours. Instead, we've condensed it way down. So it is a quick, what I'm going to share with you is a quick overview of the brain science and the ACE study, particularly the points that in the position statement that we wanted to reinforce and justify by pulling those parts out of the overall ACEs presentation to help go along with the statement. So I think we all know the basis of the ACEs study, and that is our experiences and relationships in early childhood ultimately have an impact on how we develop and grow and respond to situations later in life. Again, the study was conducted by Dr. Anda and Vince Folletti. They were working separately, in fact, one in Georgia and one in California. In the early 90s, Rob Anda was focused on prevention of heart disease, and Vince Folletti was actually stumbled upon about 80% of his patients who were obese had experienced child sexual abuse. So the two met and began the ACEs study to start to look at what adverse experiences might impact outcomes. So it's important to note that the slides today all come from the ACE interface training, which has the presentation today and the position statement have both been reviewed and endorsed by Dr. Anda. So I think that's great that he's that involved with us and really appreciates the work of our committee as well. So again, the basic brain science is at birth, there are very few neurons and neural pathways because our functioning is pretty minimal at birth. But as we grow and our environments get more complex and we have more relationships, the center by elementary age shows that our brains have developed a pretty complex network of neural pathways. That process is called arborization. And then what happens is by puberty or so, the process called pruning begins, and that is basically a use it or lose it proposition in brain development. So we develop many things, but those that we don't use, our brain tends to discard or not be as strong or not have as strong a connections to deal with those things. So the way this might look, there are a couple of different paths that we talk about in the training, and that is the upper path would represent an environment that's sort of mean and dangerous for a young person. So surrounded by conflict, violence, they may be abused, etc. Their brains develop a really strong fight or flight mechanism. And so that's becomes literally how they're wired to respond to situations. Where the lower path, that's more of a kind and generous path, we talk about it as the benevolent path. People are wired to really function in safe and calm environments. So as a result of that, you can imagine the people on the upper path might have trouble managing initial responses, especially with words, and people along the bottom path might have trouble responding quickly in crisis. And where this shows up is basically when people are wired based on their early environments, and then we start to expand where we are in the world, our biology starts to collide with social constructs and social expectations. So if we think back to the young person who may have been in the more mean and dangerous path early on, a lot of the way they deal with situations is movement. They have the strong fight or flight. And then what's the first thing that we ask young kids in preschool and kindergarten to do when they come to school is sit still. So that's just a simple example of how sometimes social constructs make it challenging for young people to be part of an environment. So the parts of the brain that, and again, this is a really high level and meant to be quick so that we have time for discussion, but we just wanted to get the common language out around the brain science and the ACEs study. So the limbic system at the core of the brain, you can see the things that it regulates. It regulates a lot of our panic and fear response. There's a lot of memory functions and response to social cues. So you can imagine if you have fewer neural networks in this area, a lot of these things can be negatively impacted. The cerebellar vermis is also an area that's core in the brain science for ACEs. A great way to understand this is really peripheral vision. We can notice that there's a group of people on the sidewalk as we focus on driving down the street. And so that really shows up in things like attention deficit disorder and other learning and attention and perception issues when that part of the brain has fewer neural pathways. So again, super quick through the brain science, but now we'll get into the study. So the study really sought to analyze what effect does this toxic stress have on young people and what predictors might it give us in public health. And so back to Zach's point, it's become real popular and sometimes on the individual level, but the study was never intended to establish someone's destiny. It may tell us about risk, but again, it's not our destiny, and we'll get into why some of that's true. So as a result of the study, what an ACE score can do is give us great population surveillance. It can tell us about risk and adversity in certain populations. It's a great tool to give us a common language to talk about prevention strategies, and great research tool. But also, as Zach mentioned, it was never designed to be a diagnostic tool or a screening tool, and cut points certainly aren't intended, and we'll get to that in a couple minutes in a slide. And so it's not a predictor at the individual level. So in the ACEs study, there were several adverse conditions that were explored, and these were the top 10 that were decided on by Anda and Folletti. In 3 categories, things that happen in the home could be domestic violence or an incarcerated parent. There's physical abuse and neglect, and emotional and social. So we all agree in the committee, this may be one of the most important slides. This is Dr. Anda's handwritten explanation of how the ACE scores were derived. So they use what's called a stress biomarker to determine the stress dose response in the subjects. So it's important to know that ACE scores are an average. So in any given category, the small dots would be the stress biomarker based on a stress dose response. So those responses are averaged. So I think in the statement, we speak to that about how, and you can see in this graph that you could have a person really with a 0 or 1 with the stress biomarker way at the top. You could have a person with an 8 or even 10 ACE score with the stress biomarker at the near the bottom. So the stress dose response is not the same for all individuals and all experiences. What the average score can't take into account is frequency, severity, gender, age, when it happened to the young person. So that's why we'd like to talk about those as a population observation versus an individual, because the ACE score doesn't tell us the stress dose response for that individual. In the study, this was the breakdown of the 17,000 people that were asked about their childhood experiences. We typically do this presentation with people in the field of helping people. It's interesting to note that in those presentations, when we do ask for ACE scores anonymously and compile those, in my experience, the ACE score of 4 or more has been about double what the study was. And we do know that it's generational and can estimate that the average scores and experiences of young people today are slightly higher than the original study, which has been 25 years ago. So what the study found was the dose response relationship is a predictor of health problems, and they were able to correlate people with higher ACE scores experience higher health issues. Well, I'll show you a couple of what those were, but there were many that were studied. Smoking is one. People with higher ACE scores tend to smoke earlier, continue to smoke, and ultimately develop COPD. If you think back to the brain science, if your brain has had less development in an area that causes you to have anxiety, we know that nicotine is mostly the most readily accessible drug to deal with anxiety. So people always ask, why do people still smoke? They know it's dangerous. They know it develops disease. It's because it can help reduce the anxiety that those people may not be able to find other relief from. So again, the adverse experiences early on and the way that the brain develops forces or allows them to choose some behaviors that may ultimately cause health problems. Also, what we talk about a lot, especially in working with youth, are suicide rates, and the study correlates that people with an ACE score of 4 or more, again, that average dose response of a 4 or more would be 20 times more likely to consider suicide versus someone who had 0 or a very low dose response from ACEs. These are some of the other social public health problems, issues that we all work with and that were reviewed by the study. Again, just like the previous 2 graphs, they all point to people with higher ACE scores or a higher average stress dose response tend to experience these problems more often. In our presentations, we call this the oil slick slide. So ACEs can't be a justification for everything. There are other reasons why people experience health issues and social health issues. But the black circle in the middle, we call the oil slick, is an estimation by epidemiologists of what percentage of the population experiences this, and it's attributable to ACEs. So for example, of all people who experience significant anxiety, the study estimates that 55% of those it's attributable to a higher ACE score. So the study really, rather than being a diagnostic or screening tool, really forces us to start to think about what is prevention. Because if we know that if these things are predictable, we know we can prevent them, and we need prevention strategies to be able to do that. Some of those prevention strategies can be protective factors. In fact, the single most effective protective factor identified in later studies is a positive, caring adult relationship. So Washington State has done a lot of work with ACEs to develop some prevention strategies, and it mirrors a lot of what the purpose of CISC is and what we're doing in the state. So it's very exciting. We have the ACEs Coalition for Education, and CISC is bringing people together and expanding the leadership who understand and know how to implement ACE information and come up with prevention strategies. It's been great to develop a common language across systems so that we can all talk about the impact in the same way. The ACEs Coalition, the 50 trainers, the coming together as a result of that, we talk about the side effect of the ACEs Indiana Coalition. Most of us didn't know each other, and we're all employed across systems and different departments, and we've all developed relationships and started working together on prevention strategies that, again, have a common language. And again, a part of what CISC is set up to do, and that is across systems, get people on the same page. And if we do that, we can start to look at public health outcomes and start to make decisions that are results oriented. So again, just and a really quick plug for if any of you are interested in the full ACEs presentation, again, there are 50 people who were trained by Dr. Anda to make the presentation on the full content of the study. They're all committed to making these presentations anywhere in Indiana. We're all over the state. There's no charge. We do them virtually or in person. And that's the website if you're interested. We're happy to set that up for you. So again, that's the real quick run through of it. I hope it helped provide some justification for the statement.
Thank you, David. So yeah, just as a sort of quick closing point here is that the statement that we've circulated, we respectfully submit for your approval or endorsement as the Children's Commission. The take-home message of this is not that we shouldn't be measuring ACEs, that we shouldn't be paying attention to ACEs in Indiana, and that we shouldn't be thinking about meaningful, productive ways to apply that science to the work that we do. I think it's more about a note of caution for wise, prudent, and appropriate use of those instruments and of those tools in the work that we do. And so to that end, what I'd like to sort of offer as well is our committee's expertise and resources. We stand ready to advise, consult, help think through, serve as a sounding board around topics like this. If there's a group, an agency, et cetera, considering measuring ACEs in some form or fashion, we'd be happy to help talk and think that through and make sure that we're doing the best work we can on behalf of Hoosier kids and families. So I stop there. I suppose now, Julie, would probably be the time for any questions.
That's right.
Yes, for me, it's more of a statement. I just want to say it was a fascinating report, and I guess I'd like to dig a little deeper into it, Julie. I don't know if the rest of the commission feels the same way or not, but I think there's some things that I didn't see the differential between why some people are Cubs fans versus White Sox fans in that report, but I think we can figure that one out if we get into it a little deeper. But does anybody from the commission members have any questions?
And let me just ask quickly, David, would you mind unsharing your screen at this point?
Can you hear you?
Sometimes it takes a minute to find the stop sharing button. It should be right at the top of your PowerPoint.
He also appears very still, which makes me wonder about
Okay.
the signal.
There we go.
Okay. Hearing no questions or seeing no questions.
So I have one thing. I'm sorry. I only have one screen, so I got a little lost on my multiple screens that are up. So not being an expert on the ACEs study, but understanding very little, and I'm hoping that Zach, you can clarify for me with the information that was gathered, looking at race, breakdown by race, and how the ACEs study, is it necessarily as relevant as it should be when you when you talk about generational trauma or anything along those lines, which I agree with the position statement. So I'm just wanting to clarify just so I understand more about the ACEs study.
Yeah, thank you for the question. So in the original ACEs study, the sample was basically folks who were enrolled in the Kaiser Health Network. The sample skewed a bit more affluent, a bit more white than certainly the national population, but even the population in California and in the areas from which the sample was drawn. That said, there have been subsequent studies that have validated or replicated that general dose response effect. But I think what you're highlighting is one of the central critiques or questions related to adversity and other stressors that occur during childhood and throughout the lifespan, which is that those ACEs that are measured, those 10 items, they're sort of a crude representation of a fuller spectrum, and it's an incomplete listing of the full list of stressors that really can have an impact on health and well-being. And so that is one of several reasons why we would want to be cautious about having that score kind of be the be-all end-all determinant of, for instance, things like eligibility for particular services, or to make decisions about whether additional assessment or treatment might be warranted, if we might be missing things systematically due to all sorts of disparities and inequities. The other point I'll just note is that the original ACEs study was conducted in adults asking about their childhood experiences, and the implications of asking those questions of adults about their childhood is very different than the implications of asking a child about their current or lifetime experiences from a lot of angles, right? This is a group that appreciates that. So I think that's another reason why we would want to be cautious about sort of launching forward prematurely with some of the uses that have been discussed nationally.
Thank you for that. And thanks for bringing up asking adults versus children. I appreciate you pointing that out.
Any other questions? Comments? If not, I want to thank you guys and Dr. Adams and David. I guess David's back on. He got kicked off, so welcome back, David. But it was a great presentation, and I look forward to using this information and furthering the study to help our families and children of the state. So thank you. With that, we'll go right on next with the strategy priorities. Oh, yeah, go ahead.
Representative Vaughn, I'm sorry, were you going to go ahead and take a vote on endorsing the position statement?
That would be great. Shall we do that? Do we want to do it? Do we need a motion?
Mm-hmm.
All right, we need an emotion to move forward with the study as a position for the commission.
So moved.
Do I have a second?
Second.
All in favor, say aye.
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 Aye. Aye.
And opposed? All right, the motion carries. Thank you again. So,
Thank you.
thank you. All right, next we'll move on to the strategies and priority of child health and safety with Dr. Chris Box. Doctor, are you around? And welcome back, and I'm hoping you're feeling better. We've been praying,
Yeah.
we've been praying for you.
Thank you. I sincerely appreciate the prayers. They're working. My whole family is improving, as am I. So I've been working from home, and it hasn't been much worse than just a cold. So I'm very blessed and very grateful. Thanks for asking. I just wanted to be able to share some of the infant mortality data here, and then give an opportunity for people to ask some questions. We have the 2019 preliminary data out, and it really looks good. Can you guys see this as I pull this up? Please tell me yes.
Not yet. Have you clicked share screen and then
Oh, no.
clicked again on your slides?
Okay, so make them small. And where is share screen?
It should be at the bottom of your Zoom screen, a little green rectangle.
I do not have that.
You know what? I can do it. I'll
I'm
share
so
them.
sorry, Julie.
That's
I know
okay.
you wanted us to be big girls today and do this, and I just have not accomplished it.
It's
Oh,
no
I see
problem.
the share screen. Now I see the share screen.
Okay, do you want to do it?
Yeah, let's see if I can do it.
Okay.
I don't know why it went away. It's not doing it.
She was seeing it when you were sharing your screen, Julie. She was seeing your share screen button.
Okay, there you go. All right,
All right.
perfect.
Okay.
So you can go to the next slide. So as you know, we have faced significantly high infant mortality rates in the state of Indiana, pretty much since the beginning of when we started to keep track of infant mortality rates. We have been the worst in the Midwest and have been working very hard to improve that. Based on 2018 data, we went from being worst to being second worst, so I was pleased with that. But this year we had, again, another significant decline in our infant mortality, so that you can see the decline here. That's Indiana's overall infant mortality in the dark navy blue, from 7.5 to 7.3 to 6.8 to 6.5. At the same time, we're seeing declines across the United States in infant mortality, which is awesome. The fact that we are saving more babies. The 2020 Healthy People goal of 6, we still have not achieved. And I do believe that the 2030 goal is even lower than that. I'm thinking it's 5, but I'm not clear, but that's good. I always want us to have something to shoot for. Next slide, please. When my team brought this information to me, at first they brought the overall infant mortality rate, and I just was really like, okay, guys, I just need to see the breakdown, because that's, to me, where I know we're making progress. And as you can see here, again, you have the Indiana line in kind of the darker blue, and then you'll see the white infant mortality rate and kind of the more aqua type blue here, which has remained at or below the Healthy People goal for a number of years now. Our green line here, which is the Latinx or Hispanic population, you can see we had gone up a little bit this past year, and the further breakdown of what this is from is still kind of under review. But I do know that sudden unexpected infant death syndrome or unsafe sleep continues to be a significant proportion for our minority populations. The line in the gold here is our non-Hispanic Black population, which has gone down again. And I'm really excited about that, because that's the lowest that's been in 10 years. I do think, and I probably should mention, that 6.5 infant mortality rate for the state of Indiana is the lowest we've been since we started keeping track of this in the early 1900s. Next slide. And you can see the breakdown here. And I want to celebrate this, because there's a lot of people that have worked very, very hard on this, including our Minority Health Coalition, including our Department of Health, including our Indiana Perinatal Quality Improvement Collaborative, our hospital systems all across the state, and our providers. But it is important to still note that even though we're not 2.5 times our Black infant mortality rate over our white infant mortality rate, it's still almost 2 times. So we still have a lot of work to do. We still have a long way to go, but we seem to be headed kind of in the right direction. And Julie, you can go back to the general slide now, or just me, I guess. I do think that, I wanted to give a little bit of an update on where we are with our OB Navigator program. The original plan was in 2020, we would roll out to 20 different counties, again, based on our highest risk zip codes and our highest risk counties for infant mortality. Again, covering women who are insured by Medicaid to begin with first. We actually were rolling out this year to 22 counties despite the pandemic, and that's because of the incredible work that Karen McEwen and her team has done with the OB Navigator program. We have renamed that in doing background studies as to what names resonate with families, especially on the minority populations that we are specifically making sure that we reach. Imagine that OB Navigator didn't really resonate with them. Mm-hmm. So My Healthy Baby is the new name, and you'll be seeing that around. And it says underneath the logo, Indiana's OB Navigator program. So watch for that. But our statistics show that a large percentage of our African-American women are accepting referrals. Actually, 72% of the Black women that complete their screening are accepting referrals compared to 47% of our white women. And we have 10% more Black women who actually complete the initial screening. So the team is really excited to see that we are actually reaching the populations that we are targeting and wanting to make sure that we connect with. So the other things that I think are going on that's important is that we are continuing to do levels of care surveys now for our hospitals across the state to make sure that if they accept women with risk factors or babies with risk factors, that those hospital systems are able to manage those risk factors. And they will have completed all the level 3s in the state of Indiana, which is the highest level of care for maternal and infant care, and will actually be completing those perinatal centers for the state of Indiana, and then going on to level 2s and 1s after that. Our Maternal Mortality Review Committee has just completed their report and submitted that to the CDC, and that will be for all maternal deaths in 2018. So watch for that data to come out very soon. I'm on a panel on Saturday where I'll probably talk about some preliminary data from that. But it has been a massive undertaking, and they've done an incredible job. And as long as we keep that funded going forward, I think that is something that is critical for us to know first of all, what women in the state of Indiana are dying associated with pregnancy during the pregnancy or in that first year afterwards. Where are they located? What are the causes of those deaths? And what causes, amongst those causes, are things that we can actually impact and make a difference on? So I'm really proud of what's going on there. We have increased our fetal infant mortality review teams by 4 times across the state of Indiana. I think there's 60 some, maybe 66 off the top of my head. And 72 of our 85 delivering hospitals are now engaged with our perinatal IPQUIC substance use disorder programming and using the toolkit and referrals. So I think this is going to dovetail very, very nicely with the MOMS grant that FSSA was able to get. Was one of 10 states in the entire United States that were funded for this. That will expand postpartum care for women with substance use disorder covered by Medicaid for at least a year afterwards, and increases the intensive support not only for substance use disorder itself, but mental health disorders, and also for those social determinants of health that we know inhibit a woman's ability to get into recovery and stay there in recovery. So that's kind of my overview, Julie, but I would be happy to answer any questions that anybody might have. And Terry, you've been an incredibly intimate part of this too, so you may want to comment on this as you've been engaged from day one.
Yeah, just a little bit. Thank you. I really don't have much to add except that this is really exciting news. We really want to do everything that we can as a state to help save lives whenever we can. And this is an example of hard work paying off. We still have more to do. We all recognize that as a team, but we have to work together to do this. And I think that this program has been a great example of the collaboration between 3 big agencies, us getting together, putting our heads together, and going out boots on the ground and getting out there into the communities and talking with the people that are actually doing the work with the families to help equip them to help these moms be the moms that they want to be, and to help kids reach their first birthdays and beyond. So thanks, Chris.
My pleasure. And then Julie, I didn't know if Dr. Sullivan is on for this meeting. I know I just left another meeting with her, so she may not be on.
She's not. No, she's not.
Dr. Box, I guess on the chart you had with the racial thing, I guess to simplify a little bit for me, is there an average age of the mother or not? Do you guys not look at that?
Yes, we would have all that information. And as that comes out for 2019, I can actually come back and look at some of that stuff, tell you, what the average age of the moms who lost babies was, their coverage. I can talk to you about what the most common cause of infant mortality amongst that group was. So I can present for more information and data. This is the preliminary data for 19 that I had today.
Okay, yeah, and I didn't know if they were planned pregnancies or if they were, not planned. I guess those are a couple of questions that I would have or be interested in knowing.
Absolutely. I can make a point of doing that. And Julie, you can just let me know when you'd like to me to get back on the schedule. We think that the team will have that nailed down probably in the next 4 to 6 weeks.
Dr. Box, hi. I'm hoping you're feeling a whole lot better. I understand that things are going in the positive direction, but I don't think that they're going in the right positive direction for the African American community, for women in maternal health. I think that there's some other things that could be done and need to be done. You haven't moved the needle for African American women very much. And in Indiana, 53 out of 100,000 women are dying just by being pregnant. That is a very high number. I love the grant, the mom's grant, but we need to be able to do the same thing for all pregnant women, whether they have, how many women that have substance abuse disorder go through this program? I guess that would be one of my questions. And is there a way to open this program up that not necessarily for substance abuse, or is there any other things that the state could go after to help the African American community when it comes to women and pregnancy? I'm on that train. I'm on the train. So I'm gonna always ask that question when it comes to my population. 53 out of 100,000 is a lot of women and a lot of babies that have lost their mothers. I need a concerted, concentrated effort for African American women. Now, IMAC, of course, we have doulas down in South Bend and all along that corridor, and they're doing remarkable jobs. But there are still some things, for example, access to care in the beginning of your pregnancy is one of the things that we know that African American women are having a problem with. They don't usually see a healthcare provider till their second trimester, which to me is horrible. So I'm going to be on a concerted effort in 2021 to make sure that we help my minority women. I agree with all women, but nobody seems to be pushing for them. And that makes me, I'm not disappointed. I'm used to it. And I shouldn't be. I'm not disappointed. This is nothing that I expect less from Indiana. I shouldn't be that way. I should have a little faith that we may be helped. I don't know if that's going to happen, but I'm going to push for it. So that's my thing. I need a little more concerted effort. The graph showed it that we're not moving. It's going down, but we're still above 10. We're at 11.6. We're still above, we're still above 10. That is just unacceptable. And so, and I believe that with COVID, it has brought out the fact that, especially in maternal mortality and maternal health, that we are not winning. No, I'm not angry. I'm not defensive. My voice isn't raised. I'm used to it, but I would like for it to change.
Representative Summers, I cannot agree with you more that we need to continue to focus on the African American population. And that is why in our maternal mortality report, you will see that some of the recommendations there are things like increasing postpartum coverage for Medicaid patients. We're already at 60 days, but how can we expand that? And then the second thing, I think one of the big recommendations was more home visitation directed at particular at-risk populations. And I do believe, and I've said this from the very beginning, that when you connect more at-risk populations to home visitation and support, you will not only help the infant health, but you will help the maternal health. I'm a very strong believer in that, and that is one of the big things that came out of the maternal mortality report. So I think it's continuing to grow and support My Healthy Baby and making sure that, as you say, that those individuals that are being hired and being out, that are going to be out in our communities, that they reflect the communities that they serve. And I think that that is a really big goal for both Director Stingdon and myself. Engaging healthy families across the state has been an incredible plus with this. And I will tell you that it's been very helpful. I'm anxious to get more data back from Minority Health Coalition about the doula programs and to see that grow, because we've funded that quite a bit through the safety pin dollars. So I'm really hoping to see that start to translate into numbers of women served.
And I also believe that it needs to expand. You know, right now we're in those counties in the north. And I do believe that one of the biggest counties that needs help is the one that I live in, which is Marion County. And I think the doula program needs to expand here and more African-American doulas hired.
Do not disagree with that. I really would like to see some data. So I'll be working with Tony Gillespie so that we can get some more of that good data, so that we'll be able to show that we are actually engaging women and connecting them with doulas in our northern part of our state. But I always appreciate your support, Representative Summers. You know that. I know that we haven't reached where we want to be yet, 100%. And I don't want you to get the impression that we're doing a victory lap here. But I do think that for those people that have been working really, really hard on this, and for the programming that's been developed, for the legislators that have funded this, it's important to recognize that the needle is moving in the right direction, that we still have a long way to go, and that we are not giving up.
I appreciate it, but I'm gonna still say the needle's not moving for me. So, I mean, it's just not moving from my community the way it should. I don't want to take up any more time. I thank you for listening to me, and thank all the committee members for listening to my little ramble. Thank you very much.
Dr. Box, I just have a quick question. Can you detail what My Healthy Baby program provides to the mothers that participate?
Absolutely. So My Healthy Baby is basically a program, the OB Navigator program. And basically what that does is we at FSSA, Jen Sullivan and her team, are identifying women as early as possible in pregnancy through things like a pending Medicaid application or an approved Medicaid application, a Medicaid charge through the emergency room, sometimes direct referrals into the program by someone else who's been in the program or a healthcare provider. And then what we do is actually refer those women over to the Indiana Department of Health, and we reach out to them and talk to them if they call us back about the program, and that this actually involves basically having a home visitor, but we don't even say that. It's more of a pregnancy support person that could meet you in your home, could meet you at the local McDonald's or the library or Starbucks or wherever it is that you're most comfortable. And then that individual is to those things that Representative Summer said, you know, like, have you engaged in pregnancy care? Oh, well, I'm waiting on my Medicaid application to be finalized. Well, did you know that you can go even with preliminary approval, and this is all it takes? And where would you like to get your care, and how can we help you do that? And do you have what you need to keep your lights turned on? Do you have a place to live? Do you have safe access to food? Do you have transportation to get to your appointments? It's really a way to try to make sure that we address those things that I, as a provider, never understood. When my patient didn't show up in the office, you know, and I made a particular point to say, I'll be here at 7 in the morning or 7:30 in the morning, or I'll be here at noon over my noon hour to see you, and they didn't come. You know, a lot of times it wasn't because they didn't want to come, but they didn't have the transportation. They didn't have the childcare. They had to get to work. There are all these barriers that we as clinicians in our office don't always know about. So it's a way to try to connect within communities women to that support, and then follow them through the pregnancy and for the first year of the baby's life thereafter, because we know the needs don't quit just because you've delivered your baby. In fact, I will tell you that pregnancy was a piece of cake for me. My first baby, when it came into the world, I'm like, oh my gosh, what is this person who needs me 24/7, you know? And so that ability to make sure that they still have what they need to parent and to provide food and to work and to get to their postpartum appointments and follow up those things that we may have identified during pregnancy, whether it's an abnormal pap smear or high blood pressure or diabetes, whatever that is, to make sure that we continue to care for that mom. And then, you know, Terry and I and Jen have done a lot of talking about what is the step after that, right? People don't quit just at age 1 for that baby needing help. So what other community programming is available within communities? And that's why having connection to these particular community programs lets us know what are the next steps. Is there a parent, you know, is there a pre-to-3 program? What is the program that we can then have that safe and warm handoff? So it's a process, Bernice, that's still in the process of being made. But what we found is a lot of times just getting people together within these communities, they started connecting and talking and realizing, oh, you've got this and you provide this and we didn't know you existed, and how can we connect with you? And so it was less about what maybe even Terry and I and Jen were doing in coming there and talking about the program, and more about that connectivity within communities that I think makes a difference. Did that help a little bit?
It helped a great deal, and thank you for that. And I'm glad to hear that it's continuing to evolve. Some programs that I've been reading about, there's one in Harlem that I learned about that's connected to the Harlem Children's Zone. They partner with new mothers, I think, to the age of 3. And so I'm glad to hear that there's some thought or conversation around that, because I think obviously that would help tremendously. So thank you all.
Yeah, so Bernice, I'd love if you have that reference to have that, and I will look at that. My team will look at it. I know that Jen has tried to make it a priority that women engaged in this program then would be able to be engaged with the preschool care for their kids, the state-supported preschools. So I think all of that is what we want to continue to build out, and this is, honestly, I believe it's boots on the ground, community by community. How do we do this? And so it takes time, but I think just the fact that we're talking about this and working on it and bringing it up has been a tremendous help.
Any other questions? If not, Doctor, thank you again, and it's glad to see you're doing well, and wish you speedy recovery. And but it was a great presentation and a great discussion too.
Thank you very much. Everybody have a blessed day.
All right, so thank you again. And next we're going to go to agenda number 5, which is the strategy priority in mental health and substance abuse with Bethany Eckler, along with Claire Fitting Green and Sarah Hawkins, and several others. So
Good morning, everyone. I'm going to get my screen shared here. Can we all, there we go. Is that working?
Yep.
Okay, great. So again, my name is Bethany Eckler. I am the School and Community-Based Programs Director with the Indiana Division of Mental Health and Addiction. I actually sit on the Education Outcomes Task Force, but was asked to present about the substance abuse and substance abuse prevention and mental health promotion programs that we manage at DMHA. And so I'm going to just give an overview and provide some state context about the programming that we do from DMHA before we hear from the Richard M. Fairbanks Foundation on their programming. So just kind of as an overview, we have funding for school-based prevention programming. There are two different methods that these get employed. They both support evidence-based practices, and I'll get into that later. And then I'm going to provide some goals and outcomes that we are working on for the youth that are being served. And so when we look at the two different types of ways that we implement these programs, there is state funding and there's federal funding. And so we have a dedicated amount within our State Child Psychiatric Services Fund that is dedicated for school-based prevention programming. And then we have our substance abuse prevention block grant funding from SAMHSA, our federal funder. And so you can see the amounts there. There are a lot of differences, and there's some similarities. And so for the state funds, we have 3.5 million, and that is divided up across 3 regional contractors. And that is a new model that we're doing. And so I'll get into some of that in the next few slides. For the federal funds, that is granted out to 15 different strategic prevention framework communities. They both serve schools. It is done in different ways. The federal funds goes to schools after school programs and is used through media. The state funds is really focused on school-based programming and working with the communities that partner with the schools. The target populations, it is legislatively written that the state funds will serve students, teachers, parents, and the community. So we've got quite a broad range of target population there. And then for the federal funds, it's youth and their parents or caregivers that are the target population. For evaluation piece of this, we have a statewide evaluator in Indiana Youth Institute. However, each of the 3 regional providers have their own individual evaluators. And so again, I'll get into some of this in the slides that follow. And then the federal funds, they work with Prevention Insights and now TPMA on the data collection from all of their SPF sites. And then just kind of in general, the frameworks that are being used is the Strategic Prevention Framework, and I'll show that on the next slide. With our state funds, we have a little more flexibility, and so we're really bringing in the multi-tiered systems of support model that our school system, the Department of Education, is supporting and encouraging schools to utilize in their mental health frameworks. So we will go to the next slide and see those. And so here you can see the SPF framework. It goes through the steps of assessment, capacity building, planning, define what prevention needs are needed, implementation of the evidence-based practices, and then evaluation of those programs, along with that context of cultural competence and sustainability. And so the federally funded programs utilize this framework very, very stringently. It also then feeds the state-funded programs. But again, we've pulled in this multi-tiered systems of support framework to really be partners with the schools. And this is our Indiana Department of Education's MTSS model, as you can see, with the idea that the tiered interventions and supports go from tier 1 up to tier 3. And then looking at social emotional supports, academic supports, and behavior supports. And so we really talk about with our state funded regional providers, how do their programs fit into that model and how can they be a complement to what's going on within the school. So some history, I'm going to really dive into our state funded programs. Those are the ones that I directly work with. And so our Child Psychiatric Services Fund has that dedicated pool of money for school-based programming. And so historically, we had granted the funds out to smaller local sites, community organizations. Sometimes it was directly to schools with prevention entities and sometimes mental health providers. And that really did mirror the way that the federal funds were being granted out for the first 5 or 6 years of that, really. So in 2018 and 2019, we had actually worked up to having 18 grantees out of that 3.5 million dedicated. And we also were able in 2019 to evaluate a cohort of 10 of those sites to really start working towards what are our statewide goals with this dedicated fund, because it had been something that had been growing over the past 6 or so years. Then for fiscal year 2020, the legislation changed and we needed to shift to having 3 contractors. So we've divvied up the state into 3 regions. And I'll show that on the next slide. But if you can imagine, we had 18 sites serving many different parts of the state. And so we wanted to ensure that we were still able to serve, close to the same number of communities, students, with this new framework. And so there was a 10 county requirement for each of the regional contractors, meaning we wanted to at least reach 30 counties in the state, trying to get around a third of the state covered. And then we used those statewide goals that were developed to really guide how this regional model would be implemented. And so thinking about some of our historical outcomes, we did, as I said, the evaluation of the 10 sites in 2018 and 2019. And we found some really great evidence. There were 6,000 students served in life skills and or substance abuse prevention, and showing gains in knowledge of risks of substance use and displayed positive attitudes toward non-drug use. And then 5,500 students were receiving mental health services, in the tier 1 level, or referrals and connections to those higher intensity services. 6,700 students received training to help better identify and address suicidal behavior, along with their staff learning those kinds of skills. 2,000 faculty and staff were trained in a number of different programs, but showed improvements in knowledge of mental health indicators and available services in the community. We know that's a big issue with school staff not knowing what resources are at their disposal. And then finally, 4,000 community members were reached through various community conversations, town hall events, and over 80% reported an increase in knowledge in mental health issues and community resources. So these are the kinds of things that they had been doing prior to this regional model, just to show a little bit of the historical outcomes that we were seeing. And so now you can see, here's our regional model. We've got 3 providers. In the north, we have Lutheran Foundation. In the central region, we have Hamilton Center. And in the south, we have Youth First. And they all 3 implement this program in a number of different ways, but essentially they're all providing evidence-based practices to schools. And they cover 39 of the 92 counties. We did have each of the 3, proposed to serve more than the 10 county minimum. So we were able to get even higher than we had hoped. And we really work with them to prioritize the partnership with the school. That has been a big push with this new regional model, is that we really want to make sure if we're going to have these 3 providers that we're supporting and pushing programming through, that they are in communication with the schools and understanding what schools need, and also being there to provide the supports that we know in the prevention field are going to help their students. And also to help them align with the education system. In all of our work under school and community-based programs, we are in such close communication with the Department of Education. So we really relay that information back to our regional providers so that they understand the social emotional learning that is being supported by the Department of Education, and that MTSS model and how they can fit into it, as I said before. So this slide, I just wanted to show that there are so many programs that are being implemented. Each of the 3 providers are doing different combinations of these programs. And there may even be other programs that are not on this list that they've added in, especially because of COVID, or just as schools are seeing a specific need. When they have that great relationship that they've built, they can really adapt and meet the needs of the schools as they're seeing things change and as the world changes this year. And so you can see that list there. There's almost a lot of them are evidence-based practices. They are not required to exclusively provide evidence-based practices. So there are some programs on there that are best practices or emerging programs that they've worked with schools to bring to them. And I am going through this fairly quickly, so I'll try to have time for questions. So thinking about those statewide goals, as I said, we partnered with the Indiana Youth Institute because in previous years, we had so many grantees and they each had their own individual evaluators that we needed to streamline what were the outcomes and what was our intention with these programs. And so through the evaluation of those previous grantees and then the analysis of the 3 new providers, their goals and their programs that they had proposed to us, we developed these statewide goals. And so this is a roundup of what we really hope to be doing with these regional providers, is improving life skills, connections to the school and community, school-related behaviors, family relationships. We want to decrease positive attitudes towards substance use. We want to increase the knowledge of mental health interventions, knowledge of suicide prevention, and substance abuse prevention approaches. You know, with our school staff, our teachers, our parents, increase those skills and knowledge. And then also to increase the use of available resources and services. You can see that we were seeing some of those outcomes in previous years, and we want to continue to do that to make everyone aware of the services and resources that are already available. And then finally, to just raise awareness of youth substance use and abuse, to support, raise awareness of support for youth mental health issues, and again, available programs and resources. So these are the buckets that our three regional providers are really working on. So next I'm going to go on to our block grant funded prevention sites. Again, we have 15 funded communities. 20% of this program area is focused on primary prevention. So thinking about those increasing risk and protective factors. And so really thinking about those methods that work on primary prevention. And so they provide evidence-based and/or best practice programs, and we'll get into that in the next couple slides. And here's just kind of a reminder of who they serve and where these are implemented. So here are the 15 sites that are currently are the SPF communities that are funded. They are required to follow that SPF process. And so as such, they have community assessments where they work to identify their target populations and what the community's needs are as far as programming. And so they also have to have 70% of their funding must go to evidence-based programming. So they have a requirement when it comes to EBPs that are being implemented under their site. And so because of that, they have to have DMHA approved work plans. And so we wanted to just show you a couple of those approved sites that have begun serving this year. First is Our Place Drug and Alcohol Education Services. They're working with Fort Wayne Community Schools, specifically 7th grade classrooms. And they're also working with the Amani Family Services organization there that serves and supports immigrant and refugee families. And then you can see the programs that they've selected based on their community assessment and based on the needs of their community. These are the programs that they are going to be implementing. And then the Boys and Girls Club of Wayne County, they are working and implementing within the Boys and Girls Clubs of Wayne County, as well as their biggest presence in that county is in Wayne County schools, specifically Richmond Community Schools in the 4th through 8th grade. So they really target in ages and grades that they want to work with. And so again, you can see their programs that are listed there. And again, that is based on their assessment, and then they work with DMHA to get that approved to move forward with. And so I did add on here, I have my contact information, and then Melissa Carroll, who is here, if there are any questions about the block grant funded communities, she is really the point person for those. So that is it.
Any questions from the committee members? If not, Claire, I don't know if you're ready.
Bethany, could you stop sharing, please? Thank you.
Hi, everyone. Thank you so much for inviting us to join you today. Thanks to Julie and the commission members. I'm here today with my colleague, Sarah Hawkins, and she and I are going to co-present about our initiative that we call Prevention Matters. So very briefly about Richard M. Fairbanks Foundation, for those of you who are unfamiliar with us, we are a private charitable foundation, and we do our work in Indianapolis across 3 focus areas: education, health, and the vitality of Indianapolis. To do our work, we make grants, we commission research and evaluations, and we hold convenings and collaborate with lots of cross-sector stakeholders, including several members of the commission here today. In 2015, we adopted a funding priority focused on addressing the opioid crisis. We have since evolved that earlier this year to be SUD more broadly, but in 2015, we were just narrowly focused on OUD. And the key question we asked ourselves is, where do we focus our philanthropic resources to complement federal and state dollars that were also flowing in to try to address the crisis that all the states across the country were facing? So we began our work by commissioning a comprehensive study of the opioid crisis in Indiana with a double click on Marion County. We commissioned that from the IU Richard M. Fairbanks School of Public Health at IUPUI, and that was published in 2016. In a nutshell, there were really 3 approaches that they recommended. You have to focus on treatment, harm reduction, and then prevention. And we followed up with this report and had conversations with multiple folks doing work at the state and elsewhere to better understand their perspectives. And we heard from everybody that there was a real gap in prevention at that time, since there was so much effort around expanding access to treatment and harm reduction, for example, through naloxone distribution. So that then directed us to decide we would focus most of our health funding on prevention. And as we dug further into it, we learned that substance use disorder often begins in middle school and sometimes as early as elementary school. And that school-based prevention programs are a critical tool for helping young people avoid growing into adults who struggle with lifelong addiction. And very critically, to be effective, school-based prevention programs have to be evidence-based. Fortunately, there is a large national body of research on effective prevention programs and multiple programs from which to select. I think included in your pre-reading was a list of 25 that we curated for our Prevention Matters initiative. And the Indiana Prevention Resource Center helped us identify what they said had the very strongest evidence for programs that actually align with Indiana's health standards. One of the key characteristics of an effective program is that it is curriculum-based and taught throughout the school year. It's not enough for a school to bring in a guest speaker once a year and have them present on addiction and prevention. That's not going to change behavior of students and the culture of a school. So it really needs to be programming that's embedded into the curriculum and provided every year for successive years. And typically schools refer to prevention programming as social emotional learning programs, which they are very focused on, as we heard in the prior presentation and even in the ACEs presentation. So to inform the foundation about where we would focus our specific grants in Marion County, we did survey schools in the fall of 2017. And we learned that only 11% of schools were implementing evidence-based programs, prevention programs. Not surprisingly, the common barriers were just a simple lack of awareness of what were effective programs. We even found some schools that were implementing programs that had negative evidence that they actually made things worse. And it was really just an awareness issue. And then, of course, other barriers included lack of available training for teachers, time, and resources. Due to our grant-making history, we have funded lots of initiatives that involve change management, cultural change within organizations, and those are very challenging. And as a consequence, we're familiar with common barriers for grant-funded initiatives, which include staffing turnover, and that has been an issue in Prevention Matters. So armed with all this information, we launched an initiative that we call Prevention Matters in January of 2018. This is a $12 million commitment by our foundation, and we're a little more than halfway through that initiative. So I'm very pleased to turn things over to my colleague, Sarah Hawkins, who has been a primary leader overseeing this initiative for our foundation and takes up a lot of her time. So Sarah, over to you.
Great, thanks, Claire. So I'm just going to drill down into some of the details of the Prevention Matters initiative and then some of the lessons that we've learned. We have 27 Marion County grantees that represent 155 public and private schools. And through their prevention programs, they're serving approximately 82,000 students. From the list of evidence-based programs that was shared in the pre-reading, the majority of our grantees, or the most popular programs that have been selected, are Second Step, which is an elementary and middle school program, and then Life Skills Training, which is middle and high school. From the outset, we designed Prevention Matters to equip schools with the systems and supports necessary to be able to sustain their programs at the end of the 3-year grant period. And we've also provided technical assistance to support schools' implementation and sustainability planning. And then we're also funding a third-party evaluation and sharing our findings along the way. The Fairbanks Foundation also partners with Doug Hunsinger, the governor's drug czar, to co-convene the Indiana Substance Use Disorder Funders Collaborative, and Julie attends a number of those meetings. During one of the meetings early on in the Prevention Matters initiative, we presented about this program, and we're thrilled when 3 other funders from that group decided to replicate the initiative in the communities that they serve. So we provided them with all of our research and materials, and then have provided them with other supports as they've begun implementing their respective programs in their communities. The program's evaluation over the first 2 years has really focused on implementation quality. Research shows that it takes about 3 to 5 years before schools start to see measurable student outcomes impact. And so not surprisingly, the key findings from the first 2 years of evaluation have talked about the importance of district and school leadership. And that it also really matters that schools have a commitment to ongoing training and support for their teachers and staff. Implementing these programs with fidelity and regularly monitoring to ensure that fidelity not only ensures stronger outcomes for students, but it also ensures that these programs become ingrained into the school's daily culture, which is really critical for long-term sustainability. As schools have grappled with COVID-19, we have increased our funding to the technical assistance so that schools have additional support on how to tailor their implementation for a remote or hybrid school model. And then also to support their data collection, since that looks really different in a remote or hybrid setting. We've also invited the program developers to participate in the communities of practice that we convene that are specific to each program, so that schools are getting really targeted support from the developers related to the pandemic. Finally, we just want to share a few thoughts about scalability and sustainability of school-based prevention programs. As Claire shared from our national landscape assessment, we know that other districts and schools across the United States have found ways to sustain these same programs without ongoing philanthropic support. And as we approach the second half or tail end of our grant initiative, we want to make sure that Marion County schools are positioned for the same thing. So our experience has taught us that it's not enough to just provide schools with a list of evidence-based programs. They also need technical assistance to support their quality implementation and to help them develop the systems and processes for long-term success. It's critical that schools continue with ongoing training, both for new staff and to reinforce the fidelity measures for existing staff as booster training. And we've also found the importance of communities of practice that are organized by specific prevention programs. So for example, all of the schools implementing Second Step have a chance to learn from one another and troubleshoot or share ideas of how to overcome barriers. Schools will face recurring costs for license renewals or the replacement of curricular materials. And we know that schools need help navigating which title funds and other public funding sources can help cover these ongoing programmatic costs. If there's a goal to really scale these programs statewide, and we know, from, if you go back to the map that Bethany shared and complement kind of our programs and the other three funders, there is a lot of momentum happening across the state. In order to achieve that full statewide scale, we see a clear need for a really easily accessible statewide repository of evidence-based programs. And then to complement that with statewide communities of practice that are moderated by experts within each of the respective programs. So for example, a second step group or a Bottom life skills training group. We also see some significant opportunities for economies of scale at a statewide level when it comes to training or license fees or other hard program costs, where those costs can be shared across schools implementing the same program. And then finally, schools need that ongoing support with how to braid their funding streams to cover implementation costs in the long term. So we just want to thank you, Julie, and the rest of the commission for inviting us to present on prevention matters, and we'd be happy to answer any questions. And I can stop sharing the screen.
Great report, everybody. And I know, is there any comments or questions from the commission members? All right. Well, again, thank you very much. It was very well put together, and appreciate the efforts. And hopefully we can get a little bit more excited to see further improvements, right? So,
thank you. We do have another evaluation coming out in the next few weeks, and we'd be happy to share that with Julie if the commission members would like to see that.
I'd like to see that. Yeah, that'd be great.
Okay, great. Thank you, everyone.
thank you. All right, next we have the agenda number 6, the strategy priorities for the juvenile justice and the cross systems of youth, and our very own representative McNamara. Is Wendy available?
I am just trying to figure out how to work my system here. How about that? Okay. Thanks for everybody getting on here today to find out about this task force that I've been trying to do. Give me just a second. I got some feedback in the background. That's the problem with working at school.
I think we're all in the principal's office.
Yes, you all were in the principal's office or are in the principal's office right now, trying to multitask. It's been an interesting morning because the kids have been testing most of the morning, and it's not been without its glitches, let's put it that way. But I am pleased to let you know that this has been a mission of mine, at least for the last 2 years, has finally come to fruition, at least the beginning of that, and that's the Juvenile Justice Reform Task Force. It was really created to try to stop doing random acts of juvenile justice and really focus on making improvements systemically across the state of Indiana, and look at how we can better improve outcomes for youth across the state who find themselves in the juvenile justice system. So thanks to a grant from the Lilly Endowment, we have partnered with this a group called the Council of State Governments, or CSG. It's going to be a data-driven initiative. The partnership is with CSG is very important because they are nationally recognized. They're a nonpartisan organization, and they're going to do the preliminary assessment of what this juvenile justice system looks like across the state of Indiana. Myself and Senator Kreider are going to be co-chairing the task force right now, and we have about 40 members, I guess, that are on the immediate task force from all segments of society, from school to juvenile justice issues across the state. We try to really build it with people with expertise in mind in every area of the state who could really provide input. There's really 5 type phases to it. The first phase will be to assess the alignment of Indiana's legislative code. Second will be to identify the opportunities to leverage and build upon past and current juvenile justice reform. Third will be to establish priorities for systems improvements. We will look and evaluate Indiana's current capacity for juvenile justice data. And that's something that's always been kind of elusive for us. We do have things in place, but it's always been kind of elusive. And then the final report will be a presentation to all the key stakeholders. That's phase 1. And it's going to be about a 6 to 9 month project. What is going to be very important is finding key stakeholders across the state of Indiana for focus groups or one-on-one meetings with CSG, folks that can solicit feedback on current challenges and opportunities that we have, all with the intention of improving outcomes for youth who come into contact with the juvenile justice system. Hopefully the preliminary phase 1 assessment will give us a roadmap to be able to conduct a comprehensive analysis in phase 2, identify policies and practices to protect public safety, reduce racial and ethnic disparities, and improve outcomes for youth who come in contact. So we're basically in phase 1. Many members who are on this are on the task force. I am excited to do that. If you or anyone you know of that might need to be interviewed or would be a valuable person to be interviewed, or identify a list or what we're calling an inventory of initiatives across the state, any effort that is affecting juvenile justice, if you have the name of a person or a group or an organization, if you would either send that information to Julie, she's kind of a warehouse for it, or Nina Solomon. Nina's from CSG, and she's spearheading the project with a few others. Emily and Josh are there as well. So Nina's contact information is N Salomon, so I'll spell it out, NSALOMON @csg.org. And then you should probably have Julie's contact information. But we're looking to identify people and programs across the state and have CSG get in contact with those so that we can get a preliminary assessment of what's going on in the state. I think that's it.
Wendy, would you say, like when you say the juvenile justice system, would you also say what CASA, or would you like to see, any of the DCS or
they'll all be involved in it in one way or another. We do have a DCS representative on the task force, but the whole key is to find the people we know exist and then look for the ones that we don't. There might be a diamond in the rough somewhere. If somebody has a connection to a unique program in a community or something like that to help our youth, that would be important for CSG to know, and for us to know, to be able to put that in. I know Representative Shackelford in our last meeting gave us a group at Indianapolis that no one had really ever heard of. So it's moments like that or groups like that that would be helpful. Just last Thursday in Mount Vernon, I learned of a program called Thrive that I had never heard of before. They received a national award from the Civic Air Patrol for their work with at-risk youth, and hadn't heard of it before. It's been in my community for 12 years. So it's just things like that in talking to people like that, I think that make a big difference in putting together a picture of what Indiana looks like concerning juvenile justice.
Very good. I know the Chief Justice was a probate judge at one point. I don't know if she's, it's probably still, she has a library full of people in her mind, I bet.
She's just nodding her head, yeah.
Yeah, she's got, Representative McNamara's reached out to a lot of people in the juvenile justice area. So, I mean, it's been well, and I'm always ready to help.
And Justice David is on the task force again, and a big part of the communication. In fact, it was his idea to make sure, kind of get a menu of the groups that are out there already, or the initiatives that are out there already, so we could not just talk to people, but see what action is going on out there. So it's a who's who list of people in juvenile justice, I would say, with a few new people that I think that are going to help us make a positive impact for all kids. And my goal is, in the end, is to make sure geography by justice is not a problem. That anywhere in any part of the state, our kids, no matter where they're at, they're all afforded the same opportunities.
That's a good mission statement.
Representative Vaughn, if you don't mind, I'm going to quickly share my screen to show the Children's Commission website. Can everybody see that? And the Juvenile Justice Reform Task Force page. Did I share the correct screen?
Yep.
Okay, so just in case anybody wants to know who's on the task force, it does have its own page under committees and task forces now on the commission website. So I'm just scrolling the list of names here, but you can certainly go and take a look. And then also the first meeting of that task force was held on September 30th, and there's a recording of that meeting available on the website as well.
Very good. Hey, Wendy, how many, I guess, how many meetings do you see happening through this several month period, or how do you see it playing out a little bit?
We discussed that the last one. There's not a whole lot the task force can do other than spread the message right now of CSG being our partner and going across the state and just really putting together our story. And we had talked about one, I want to say in January. Julie will have to remind me because I've had a few Zoom calls since then. I want to say January, February, we're going to have another meeting, and then probably one when we get the results to go over the results.
Mm-hmm.
But that's just phase one. Phase one is just the gathering of the data. Phase two will actually be disaggregating and looking at and seeing what our picture is. And then phase three is probably going to be more than a year off of doing implementation and recommendations.
Awesome. Very good. Well, again, thank you. I shouldn't say Wendy, I should say representative, sorry.
No
Principal.
problem.
I haven't been in the principal's office in a long time, so.
Well, you just were, all of you. Anybody have any questions?
He'll say it wasn't my fault I was in the principal's office. It was his fault.
Absolutely. Okay.
Thank you.
No
We
problem.
look forward to seeing the outcomes and what we can do to continue to move forward to help these kids.
Yeah, thanks, Wendy.
All right. So next, I think, I don't know if Julie wants to run with it, but we want to add a youth members, maybe one or two members to our commission, and that have gone through, the foster care programs or dealing with, I guess, our system and how they grew up with our system in the state of Indiana. And I know at the last executive committee meeting, I know Terry Stigdon, Director Stigdon, I apologize for being informal, had some good comments through that as far as adding some youth members to our commission. And I guess I'd like to turn it over to Julie a little bit more.
Sure. So just to give the background, this is an idea that came up at the executive committee. So we thought it was important to bring it to the full commission and kind of see what everybody thought. As we've been working on youth engagement and kind of bringing more youth voice to the commission, And I'll, preview my announcement, which is a reminder that we have our Youth Engagement Summit on Friday, our virtual summit from 1 to 3. So I've been kind of reporting to the executive committee on progress with that. And the idea came up about adding youth to the actual commission. I think you all know you're appointed by statute, most of you, or your appointing authority is listed in the statute. So it's not, we can't just add whoever we want to the commission. It's all legislated. And so the idea came up in the executive committee to actually propose a bill to add 2 youth members to the commission. So I guess one, we wanted to discuss here, if the rest of the commission is on board with that, thinks that's a good idea. And if so, what parameters should be written into the legislation? And there's a few different specific questions. One is what age range of youth, what type of experience do we want them to have? Who would be the appointing authority and how long would their term be? I think those are kind of the key elements that would need to be written into the statute if we made that change. There's a lot of, and I'll just say this from the outset, whoever kind of is the appointing authority, I, as the staff of the commission, am ready to do whatever background work and research and recruitment needs to happen to be able to surface youth who meet the criteria that are laid out to kind of offer a short list for potential appointment like we do with the committee and task force co-chairs. So that's the background. And I think the desire is just kind of for an open discussion and get opinions from members of the commission about if you think it's a good idea or not. And again, kind of those different parameters for how we'd want to define it if we do go forward with that.
I think a 2-year term, I think maybe the executive committee appointing, you can't get, because I think the executive committee has all branches involved in it. And, Julie, I'll leave it up to you with regard to the specific language, with regard to a child that's been involved or, now an adult or young adult that's been involved in the child welfare system in Indiana. Those are my 2 cents.
Do you think, I guess I like the idea of the 2-year term only just to get a variety of fresh insight to how they went through the system as well, and to get kind of new blood kind of coming in as well. So I think I would agree with the 2-year.
I agree with all the points that were made. I like the 2-year, I like the executive committee appointing. I would be interested in hearing from the perspective of a child that was that experienced dual status, both in like a Chin's point of view and delinquency point of view. I think would be very helpful for this group.
All right. Do we need a motion, Julie?
I don't think so at this point. I think if you want, unless you want to take a vote on just the general concept of supporting adding youth members, I think that the details will need to be worked out right in a bill. And then maybe once we have a bill, we could present it to the commission for endorsement. I don't know. How does that sound?
Does it matter that we've lost the quorum?
Oh, yeah, that's true. 1, 2, 3, 4, 5, 6, 7, 8. It looks like Dr. Box might still be here. 9, 10, and Senator Donato is here. Actually, we do have a quorum.
Okay, good.
Well, does anybody object? I guess is more important. I don't think anybody or have any concerns.
No objection.
I have no objection. I would support this, and it's Chris. I have been listening.
I have no objection. I would support.
Okay, so maybe I can just work with the legislators on the commission on sort of specific language, taking into account the input you all have provided. I guess one question I sort of have is the executive committee currently is not named in the statute. There's no language in the code about the executive committee. So if we make the executive committee the appointing authority, we might have to then also enshrine in the code what the executive committee is. It's in our sort of roles and responsibilities document that we've created and you all have approved for yourselves, but it's not currently in statute. I don't know if that's a problem or not, but it seems like we probably would have to add it to statute in order to make that the appointing authority. Otherwise, it could just be the chair with the commission's understanding that the chair would make that decision in consultation with the executive committee.
I think that's a better suggestion, Julie. They're appointed by the chair. Can you hear me?
Mm-hmm. Yeah.
Oh.
Anybody else have any thoughts on that?
I'm good with the chair. Typically the chair's a, different person every year, right? So within the executive committee. So I think, and they're usually in tune with the whole executive committee anyway, and the commission as a whole.
Yeah, you all have done a really nice job on that, of really that collaborative leadership through the executive committee. It's
Say
just not
appointed by the
currently
chair.
legislated. Yeah.
Appointed by the chair in consultation with your executive committee.
Yeah, that's a possibility.
All right. Julie, do you want to continue then?
Yeah, so just to kind of wrap us up and bring us home. So we did have 2 written updates submitted by 2 of the committees, the Data Sharing and Mapping Committee and the Equity, Inclusion, and Cultural Competence Committee. So those are posted on the website and linked in the agenda. I don't know if you all had a chance to look at them and if you had any questions. Just really brief summaries on kind of what they've been up to, which is what we've asked the committees to do if they don't have a substantive agenda item to present, to just provide a little written update. So data sharing and mapping has been working to support the juvenile justice task force that you just heard about by gathering whatever data they could get their hands on around juvenile justice, and also still working on updating the information sharing guide. That has proved to be really a beast, I can tell you, because I've been involved in that process of trying to get that legal information that's in the information sharing app updated to reflect current law and really the current interpretations of the different agency councils, because that's ultimately who we're relying on for those legal opinions. So we're working hard on that, hoping to get out a version 2.0 of the app at some point. And then the Equity, Inclusion, and Cultural Competence Committee has continued to look at follow-up from the framework document, the guide for equity considerations that you all approved at the August meeting, around kind of some questions to ask when you're making decisions to make sure you're making those decisions with an equity point of view. They're trying to determine some ways to maybe offer technical assistance if folks want it, to be able to implement that tool. And then the next thing they're working on is actually some guidance for agencies that want to hire a sort of equity director position or chief equity officer, or, that goes by lots of titles. And the committee is going to work on putting together some guidance on kind of best practices to set that person up for success if either an agency has one or is hiring one. So that's what's going on in those 2 committees based on the updates that they submitted. And then the only other thing I was going to offer is, and I already said it, the Youth Engagement Summit is this Friday from 1 to 3. I hope everybody has registered. If you haven't, I can probably still get you in. Just send me an email and let me know if you're free to attend. It's the format is going to be, it's going to be on Zoom. They're going to start with a panel of youth kind of describing their different experiences and highlighting the 4 topics that they've chosen. The youth have really chosen to drill down in, and then there's going to be breakout sessions. So everybody will go to one of those 4 topics and hear more in depth from the youth on both their experiences and their proposals, and then come back together as a group. And the 4 topics are education and economic inequity, housing, homelessness, and eviction, DCS and the juvenile justice system, and then mental health. So everybody, when they register, is asked to kind of rank those 4 topics, and then they'll be assigned to breakout, just one of the breakout rooms based on your preferences when you register. So let me know if you want to attend and you haven't yet registered, and we'll get you signed up.
I thought I registered, but I don't think I got anything back. Who would it have been under on the email?
A confirmation with the Zoom link was just sent yesterday by Lauren Hall. That's the staff person at the local nonprofit that we've been working with.
Lauren Hall?
Yep.
Yep, got one. Okay, there it is, right there.
So that's your Zoom link, and just go there at 1 o'clock on Friday, and we'll hear from the youth and hear what they have to say. And then hopefully there will be some follow-up coming out of that as well. So it's not just a one-time event, but again, as we've been talking about this whole issue of youth engagement, we all as professionals run or work in systems that are designed to serve youth, but we seldom actually get to hear from the youth directly. And we know that our decisions will be better if we're hearing from the people that are affected by those decisions. So we want to try to find ways to build that in. Your support for adding youth members is a huge one. And hopefully there'll be more coming out of this summit on Friday. So that's
Julie,
what I have.
what time and how long is that summit?
It's from 1 p.m. to 3 p.m.
Thank
on
you.
Friday. Eastern time, sorry. If anybody's on Central time, it's 1 to 3 Eastern.
Awesome.
Representative Devon, that's all I have.
All right. Well, I want to say, I want to say thank you to everybody that's working so hard. And if I can just take a moment of privilege, Julie, and I just, with Dr. Box and the Chief Justice, and I'd like to say a prayer. I know we don't normally pray, but if you guys would allow me to pray for their health and just for our leaders and for our state and for our children, I appreciate it. Father, we just come to you today. I thank you for just the state that we live in, this world that you give us, Father, to live in, and that you ask us to manage your children and to better equip our leaders, Father. So I pray for the Chief and Justice and for her health, as well as Dr. Box and anybody else that might be feeling ill because of the COVID or any other illnesses that might be in their system. But we just pray for healing. Father, we pray for your favor over each one of us here and our families, and but just the ability to give us wisdom to help further these kids' lives, Father. And we ask it in Christ's name. Amen.
Amen.
Thank you all.
Thank you, Representative Devon. That was very awesome.
Thank you. I appreciate it as well. I'm feeling it. I need it.
We love you all. So stay strong and stay healthy. All right. We'll see you next, what's it, January 15th?
December 15th.
Oh, okay. I was trying to push it off farther. So, okay, December 15th. So enjoy your Thanksgiving if we don't talk before then. And thanks again for everybody to be a part of this.